Please listen carefully.
Hello and welcome to GasGasGas, your one-stop podcast for the FRCA primary exam. This podcast will fill your brain with information. Listen to it, think about it, and check out the show notes on the website. There you will find the core diagrams you need to be able to draw and describe for the exam. This podcast can squeeze into your day. Listen while you're driving to work, cooking dinner, maybe when you're on call, or in the gym. Eventually the revision is going to end. But for now, expect facts, concepts, model answers, and the odd tangent. Remember to rate and follow the show to hear much more. Hello, my fellow GasGasGas compatriots. Today is the first VivaCast with my willing victim, Tom. Now, whilst it might be tempting to put the Viva to the back of your mind and focus on the SBA, the content heavily complements each other, as you would expect. So I would thoroughly recommend you have the courage to practice for the Viva as well as studying for the exam. Bearing in mind, I didn't have the courage. So, Tom, who are you and where are you in your exams?
I'm Tom. I'm a CT3 trainee in the Northwest. I've recently passed my written back in September, and I'm waiting to sit the Viva in January.
We are going to pile straight into quiz action. Tom is ready and raring post night shift. We'll then review what we've spoken about and try and sharpen things up a little bit. So, Tom, this is your physics and equipment Viva. So what is the difference between preparing a laryngoscope blade for reuse relative to a laparoscope or a stethoscope?
So there are different levels of preparing equipment that are linked to their categorization as critical, semi-critical, or non-critical. Critical pieces of equipment enter parts of the body that are normally sterile and thus have to be cleaned to the highest degree, and we can talk about the levels in a moment. Semi-critical equipment makes contact with mucous membranes or broken skin and still has to be cleaned to a higher degree than equipment that does not do that. And non-critical equipment contacts intact skin or is just present in clinical areas and can be cleaned again to a less high degree. Now, the levels are divided up into sterilisation at one end of the spectrum, disinfection in the middle, and cleaning. Cleaning is a fairly common sense definition, really. It's usually using soap or surfactants to remove contaminants from the outside of an object. That can include blood, feces, and things like that. Disinfection involves bringing microorganisms down to a safer level, but not necessarily destroying them all, and not normally including bacterial spores, such as Clostridia, for instance. So the critical equipment that's going to enter parts of the body that are normally sterile has to be sterilised. Now, sterilised meaning all living organisms are killed on that object so as to prevent cross-infection. And there are different techniques for achieving all of these. So we mentioned at the beginning that soap and surfactants can be used for cleaning. At the other end of the spectrum, sterilisation, there are different ways to sterilise equipment. Firstly, using steam, so primarily utilising heat from heated water, essentially. We can use irradiation, so gamma rays being a fairly common technique for killing microorganisms on equipment that requires sterilising. Or we can use... There is a way of using pressurized gas to to sterilize equipment as well. The name of the gas escapes me just now, but there is one that's in relatively common use. In the middle, for disinfection, we can use solutions such as hypochlorite solutions or alcohols that will kill most living organisms on surfaces when exposed for appropriate amounts of time. But they, as mentioned before, don't normally remove bacterial spores. Prior to sterilisation or disinfection, cleaning is an essential first part because you need to remove contaminants from equipment before you can properly disinfect or sterilise.
So that was a structured answer where you broke it down into semi-critical, very critical, and non-critical stuff, and then broke down the requirement standard of cleanliness or sterilisation relative to that. It might be easier to bullet point things a little bit more. The pertinent thing to mention with cleaning, beyond just removing debris, is that often it's done at sub 45 degree temperatures to stop the alteration of proteins that might make it harder to clean the thing in the first place. Disinfected things. You mentioned chemical disinfection methods, alcohols, hypochlorites, and some aldehydes as well. Or moist heat, i.e. 100 degrees C water for 10 minutes. Kills everything except for the bacterial spores you mentioned there, Tom.
Yeah, okay. Yeah, makes sense.
Yeah. The other two things to mention on the disinfection front is pasteurization. So if you have something at 77 degrees for 30 minutes, it kills off most bugs, but not all. And then glutaraldehyde is probably the chemical to mention of the aldehydes, which is used for cleaning endoscopes.
Sure. And is it effective against mycobacteria if given enough time and things as well, which I think can be more resistant to some of the other solutions? Yeah, okay.
Yeah, if you cook it for long enough. And the gas you were trying to think of for achieving sterilization is ethylene oxide.
Yeah.
Yeah. It's colourless, it's inhalationally toxic, it costs a bit, and it takes 2 to 24 hours of exposure for it to actually sterilise stuff. So I think it's quite expensive to achieve sterile equipment, isn't it?
Yeah. Lots of equipment, chemicals, and various procedures involved.
The last thing is just to make sure we're definitely hot on those definitions. So, cleaning is the process of removing contaminants, dust, soil, large amounts of microorganisms, blood. But you can't disinfect or sterilise something until it's clean. There's a term bioburden. That's just the gunk and general detritus that's on whatever thing you're trying to clean. Tom mentioned that disinfection is reducing the number of microorganisms, but not bacterial spores like Clostridia, reducing those bug levels to a sub-harmful level of health. Sterilisation is annihilating everything under the sun that is lurking on that device. He mentioned stratifying the risk of where you're going with that device. So a critical or high risk area is sterile cavities within the body, and anything that goes there also has to be sterile. Laparoscope, needle, scalpel, etc. Semi-critical or intermediate risk is those coming in contact with mucous membranes or broken skin, I think, was it, Tom?
Yeah, mucous membranes or broken skin is my understanding, yeah.
That would be things like your laryngoscopes, your endoscopes, and maybe your sigmoidoscopes. And then non-critical or low is stuff that comes into contact with skin. So your stethoscope just needs to be clean and dry.
Excellent. And just thinking about exam technique a little bit as well, I suppose the question itself did mention laryngoscopes and endoscopes. So some specific reference to the technique used for those, as you mentioned, talking about aldehyde endoscopes, will probably pick up some of the marks.
Yeah. And then you might close out with, if you've got to the end of that and they're still asking you questions and they're asking you about irradiation with gamma rays or how stuff might be packaged and taken into theatre, then you're doing really well because you'll have answered all the core bulk of questions, but they will just keep asking you questions until that time goes bing and they move you on. Expect to spend 5 minutes on each sort of subject area, and really you want to spend a couple of minutes talking. They might and or try and move you on. Try not to spend the whole 5 minutes talking, and try to let your examiner in, because if you just keep talking, you might talk yourself off topic and they might not get where they want to go. So you've got to have some natural pauses where they might think, okay, and tell me, that's fine, tell me about. Right, how did you feel that went?
Yeah, okay. Maybe a little bit lacking on the detail, but I felt able to structure it, which is half the battle sometimes.
Always have a decent structure or a fallback structure like pre-op, intra-op, peri-op, or bullet point things and then hang off of that to make it sound like you know what you're on about, which is half the game. So, Tom, that was your physics and equipment 5-minute subsection Viva, because that would only be 5 minutes in the exam. Hello, everyone. That was Tom. I am James. This was the GasGasGas VivaCast, and it was the first time that we've recorded something over the internet. We spent quite a lot of time scratching our head and trying to make it work. We are not sound engineers. But if it was useful, email me and let me know. My email address is on the website. Next time, Tom does physiology, and then I drag him backwards through a hedge doing pharmacology. Yes. If you found it useful, or awful, please like and subscribe and rate the show. Definitely check out the show notes for those diagrams and the detail of this content. It is a bucket of content to get to grips with. Keep working at it, and you will get better, faster, and stronger. It is vital to keep your interest live for the science that we're covering and not overcook yourself. You will be amazed by what you know come exam day. Don't freak out, keep studying.